Welcome. This is the institute that we're talking about. So this is the Mental Health Technology Transfer Center. We prefer to call it MHTTC for short. So this area right here is what I was referring to. Go back, you can see the whole map. And this is the purple, pretty purple part that I was talking about. Okay. Okay. On this slide, you'll see our wonderful team who have all contributed to make this event possible. For today's webinar, you'll be getting assistance from Alicia, our program administrator, Nadia, the one that you've been hearing, giving me cues all the time, and the one that you will see in the chat. She's our trauma-informed specialist, and myself, Ari, behavioral health equity specialist. Before we start this webcast, let's go through some things to help with the navigation and completion of it. Please type your questions in the chat box. We'll be collecting those and we'll address them when we move to the question and answer segment at the end of the presentation. Remember that the chat will be saved, including the messages that are sent privately. Just keep that in mind. If you're experiencing any technical difficulties, please contact Nadia through the chat box or via email at nadia.kalinchuk@austin.utexas.edu. Now let's talk about pronouns. Let's add our pronouns to our display names. This will help us going through the Q&A section. So if you can, please go to your image and point your cursor on the screen. You'll see a dot, dot, dot on the top right of your square. And then once you click that, click rename. Let me do it myself so you can see how it would look like. So you click here to rename. And then you can put it on parentheses, you put your pronouns, and check on Nadia if you have any technical problems doing that. Another important thing for this webcast, please, we ask you to please complete the post-event evaluation of today's webcast. In order for us to continue to provide free events like this one, we're required to collect anonymous evaluations from participants and report the results. At the end of our webcast, I will display a link to the evaluations that you can use to complete it immediately. Please follow the instructions accordingly and email me at any time if you have questions. Let's talk about CEUs. So you'll have your CEUs with your certificate of completion after you complete the post-event survey. This survey will function as your post-test for today's event. After you complete the evaluation survey, immediately after the event, email me adding CEUs to the subject of the message, and I'll be sending you a certificate. Don't worry, I'll share more of these details when our webcast ends. This webinar has a healing center and trauma-informed perspective. So Nadia, as our trauma-informed specialist, will go through some important points that will help us during this.
Okay, thank you so much for your time and for being here today. Holding a healing-centered space means acknowledging the pervasiveness of trauma, how it may show up today in our lives and in this learning space, and doing our best to facilitate learning that honors that experience. While the content of this webcast is not focused on trauma, one's own experience of trauma may come up. One way we can be responsive, healing-centered, and recovery-oriented in this space is to normalize that which we know is real. Trauma is real. The content we cover together may bring up feelings, memories, and experiences. We want to make space for this and all the variety of responses that come with sharing content that may be activating or re-traumatizing, while actively working to limit or contain such content. To that end, next slide. To that end, we want to offer up a few options with you, the virtual learner, in mind. If you see an offering that speaks to you or that you appreciate, use your reactions on your toolbar to provide a clap or a thumbs up. First and foremost, you have the option to be visible or shut your camera off. This ensures your comfort and safety in what you share. You can do this by going to your Zoom toolbar and selecting and clicking on the video camera. This will cause a strike through of the icon, which you can also undo at any point. Please note that we have everyone muted on the call, so this limits the outside noise and distractions. You may inadvertently unmute yourself, but if you do that, please mute yourself. Understanding that the current context and everything shifting to Zoom can cause fatigue, you can choose to hide yourself so that you don't have to look at your own image on screen during the webcast. And I apologize, I don't have mine, my video on, but I did hear people say that they would like to see the person who's speaking. So there you get to see me. So understanding that the current context and everything shifting to Zoom can cause fatigue, you can choose to hide yourself so that you don't have to look at your own image on screen during the webcast. You can do this by hovering over the 3 dots on the top corner of your image and clicking on Hide Self. That's exactly the same 3 dots that help you rename to. In addition, you can switch from gallery, where you can see multiple people, to speaker view. This will reduce the amount of stimuli you encounter. This session is being recorded. And next slide. The panelists on today's webcast have been very deliberate in the presentation of their material. They provide warnings and information for you to make the decisions you need to care for yourself in the best way possible. We are supplementing this by offering a few different options to make space for yourself and your needs. We have set up a breakout room. You can reach out to me privately via the chat box and let me know you would like to be placed in the virtual breakout room. A staff member will be there to provide support. We can bring you back into the webcast when you feel ready to rejoin. You can also walk away from your screen and come back when you feel ready to rejoin. If you choose to leave early, please let us know. While sometimes leaving early just means making enough time to get to another meeting, checking in with us actually provides us with the information that you're well, and whether you or not you would want us to check on you later. Finally, we're locking this webinar to support the safety of this learning space. So when we finish introductions, we will be locking this space. Again, we hope that you feel safe and supported in this learning space, and we will stay behind after the webcast to answer any questions. Thank you.
Thank you, Nadia. I saw somebody saying that they couldn't see me, so hi, this is Ari. Let's keep this. Let me see. Okay. So thank you so much, Nadia, for that awesome information. Now let's meet our presenters. We're thrilled to see the interest that our webcast generated, and we're really proud to feature such wonderful experts from the Counseling Psychology PhD program at the University of Houston. We're also members of the CORE, Coping and Resilience research team, which focuses on LGBTQ+ health disparities. They are Sana Flynn, Erica Ray, and Danny Soltis. Thank you for being here and for sharing your research and knowledge about this important topic with us. So now, without any further ado, let's start our webinar.
Hi all, we're so glad to partner with South Southwest MHTTC and are happy that we have so many folks interested in learning more about gender diversity and learning how to provide more affirmative care. Thank you all for joining us. My name is Erica Ray.
I'm Sana Flynn.
And I'm Danny Soltis.
So today we are curious where everyone is joining us from. If we can please launch the first poll, please. And we'll take just a second as everyone has an opportunity to kind of look this over and submit your poll information. We'll take just a few more seconds doing this. Okay, we should have the results of that poll very shortly.
Nadia, we can't see the poll. Are you able to launch it? If not, we can just use the chat. We just need to see if we have it.
So there is a poll, 190 people have participated in it so far.
Oh, okay, so let's just have to wait. Then, since there's a lot of participants in this webcast today, it's probably going to take a few minutes to reach out to everyone. Okay, thank you.
So it looks like, at least in the chat area, that we've got several people joining us. Let's see, from state mental health agencies, some public schools, some community centers, LGBT life centers, Justice Department. Oh, there we go. So a lot of people are from other locations, it looks like, and it looks like we have the largest percentage joining us from community clinics. So welcome everyone, and we hope today to provide you with some information that will be valuable to you from wherever you are practicing from, and that this information will help you serve all of your gender diverse clients in a more affirming way. Today, I'll be talking about issues related to transgender health. I want to acknowledge that I am a cisgender person with cisgender privilege, and even though I work with the trans community, I do not assume that I am an expert or that I truly understand what it is like to be a trans or gender diverse person. All right, let's get started. Next slide, please. So before we get started, we would like to remind everyone that the opinions and commentaries herein are our own and do not necessarily reflect those of our program or the University of Houston. Additionally, we have chosen to include content warnings in different areas of the presentation to warn the audience before we begin discussion of such topics such as transphobia and slurs, non-affirmation of gender identity, suicide, victimization, substance use, and mistreatment by care providers. You'll see the triangle icon at the bottom of the screen appear before the slides warning which topic is coming up and approximately how long we'll be discussing that subject so that you can mute the volume or step away as needed or employ some of the strategies that Nadia discussed. Next slide, please. So today we'll be discussing aspects of trans history and how that relates to why this work is so crucial. We'll also review major health disparities that gender diverse folks often face, as well as the impacts of microaggressions and stigma. We'll cover different models of care that have been used with trans populations in the past and make suggestions about how to best support your trans clients with affirmative practices. Next slide, please. So throughout history and all over the world, transgender and non-binary folks have existed. For at least the last 100 years, we have evidence that trans and non-binary people have been largely pathologized and mistreated by providers under the guise of care. Some folks may be familiar with Dr. Magnus Hirschfeld, who was a German sexologist and pioneer of gender-confirming surgeries around the World War I era. After the emergence of Hirschfeld, there were also other physicians who became vocal about either their support for or denial of early transgender rights. Michael Dillon, a trans man himself, was an early advocate for access to hormonal and surgical interventions. David Caldwell, on the other hand, made a distinction between biological sex and psychological sex, and unfortunately advocated that trans people be treated as though they had a mental disorder. In the 1950s and 60s, there was some media visibility for the trans community when Christine Jorgensen graced the front of the New York Daily News and gained some celebrity. Dr. Harry Benjamin, an endocrinologist, was an early advocate for transgender rights. He was one of the first healthcare providers to see gender as existing on a continuum and was an advocate for access to medical interventions here in America, mainly through emergent gender identity clinics, of which there were a few of note. He formed the Harry Benjamin International Gender Dysphoria Association, which would later go on to become WPATH, one of the leading contemporary organizations guiding the way with standards of care for transgender folks. A little later, there was Dr. Sandra Bem, who illuminated the incongruence and dissatisfaction between societal sex roles and the assignment of those sex roles. There was also a move to privatization of care after some literature was released arguing that gender-affirming surgeries at gender clinics did not improve psychosocial outcomes for clients. Incidentally, this was what prompted the issuance of WPATH's first standards of care. Next slide, please. In the 80s, we began to see the emergence of diagnoses for transgender and non-binary folks in the DSM-3. Unfortunately, gender identity disorder, or GID, was viewed and lexically approached in and of itself as a disorder, thus setting up a medical model of treatment and the pathologization of trans folks. Though some of the diagnostic criteria became more specified in the DSM-4, it was not until the DSM-5 in 2013 that the term GID was abandoned for gender dysphoria. Sana will discuss this a bit more soon. In the time leading up to the release of the DSM-5, the APA did release a fact sheet stating that gender dysphoria is not a disorder in and of itself, but rather that embodied dysphoria should be diagnosed to alleviate the resultant distress that the individual may experience. In the ICD-10, there is still reference to problematic terminology, but the release of the ICD-11 will include an update to gender incongruence, which is also emblematic of the necessary move away from pathologizing terminology and intervention stance. Though the providers mentioned here were largely trans advocates, it is important to note that they stood out from the majority of clinicians and societal stances. Throughout this brief history, transgender and non-binary people have faced scrutinization, discrimination, and direct harm through the employment of the medical model. Until very recently, transgender people everywhere have faced pathologization from healthcare providers simply for expressing and sharing their identity. As a care provider for trans clients, it is part of your duty to recognize the reality of this dark past and to provide opportunities to change that narrative and to build trust and respect in your therapeutic relationships. Only this type of work can be reparative and healing for clients who may not be, and rightfully so, trusting of the mental health field and other healthcare providers. Next slide, please. This is the Gender Unicorn. And if you're unfamiliar, it is a great tool for understanding the complexities of gender, sex assignment, and sexuality. A simple way to approach this is to consider gender identity being a felt understanding of who you are as a person or who you go to sleep as every night. Gender identities exist on a spectrum, and there are infinite ways in which someone can identify their gender. Gender expression can also be varied and is a way a person communicates their gender through behavior, clothing, and/or characteristics. And that expression may not be congruent with societal standards of role expression within specific cultural context. People in the West are typically assigned male or assigned female at birth based on only one aspect of sex, external genitalia, regardless of the other factors that contribute to sexual differentiation. Who someone is physically and emotionally attracted to is related to sexual or romantic orientation, and this ultimately intersects with gender identity to inform how someone comes to understand who they are. We will not go into very basic Trans 101 here, but we will cover some newer terms that are currently accepted in the lexicon. It is important to note that language in this field and broadly can change quickly, and so it's important to stay connected to trans and non-binary communities and to continue education regarding terminology regularly. Next slide, please. So transgender is an umbrella term that encompasses infinite genders. A transgender person is someone whose gender identity does not align with the sex that they were assigned at birth. This term, transgender, should always be used as an adjective and never as a noun or a verb. Next slide, please. Non-binary is also an umbrella term, and that includes people who may experience their identity as existing somewhere on a continuum. A non-binary person may identify within the larger trans community and is someone who identifies within a spectrum that is not specifically tethered by masculine or feminine binaries, or more simply, someone who identifies with a gender other than male or female. Again, non-binary should be used as an adjective and never as a noun or a verb. For a good guide to 101 language, please see the link in the references section to the GLAAD Media Glossary of Transgender Terms. Next slide, please. So here's a list of identities that may be encompassed within the non-binary umbrella. Please note that this list is not exhaustive, but it might help you become more familiar with labels that people may identify with. Next slide, please. So intersectionality was first termed by Kimberly Crenshaw and is an important framework to understand and recognize the many different aspects of a person's identity. You may also be familiar with Pamela Hayes's addressing model, which calls for examining cultural influences that overlap to reflect sociocultural diversity. Please consider both models when working with transgender and gender diverse clients. The person sitting in front of you is not only their gender identity, but also a person who faces many recognitions, responsibilities, and obstacles in the world for who they exist as. People who exist under multiple oppressions or at the intersections of several marginalized identities will be the most likely to need access to affirming care and also the most likely to face the most barriers in accessing care. When planning care and treatment, it is important to recognize that the many parts of a person sitting with you, so you can begin to understand their unique identity constellation and lived experience. It's also important to recognize that transgender and non-binary communities are not monolithic, and to remember that each client will have their own individualized gender journey, which may or may not relate to the reason that they present for care. Just as it is recommended that you should be aware of your own gender development and exploration, you should also be comfortable with the exploration of other aspects of your own identity. Having a better understanding of the different ways that aspects of your identity interact to determine who you are and who you present as in the world will help build recognitions for the complexities of individual identity. Next slide, please. So back to terminology, make sure that you are using words that are found here in the right-hand column as opposed to the left-hand column, as the ones in the right-hand column are going to be more inclusive. Some of these outdated terms in the left-hand column, such as FTM or MTF, were once used within the community and literature, and some community members may still prefer these terms. It is important to be cognizant that terminology is always evolving and to recognize that the same term may have different meanings for different people. While you should stay knowledgeable about the current and most appropriate terminology, you should always defer to what your client is comfortable with and uses for themselves. There are also certainly in-group words that one would want to stay away from if you're not a member of the in-group, and you would certainly never want to fix or adjust a client's self-defined language. As you can see in the right-hand column, the use of terms such as trans woman or trans man and assigned female or assigned male at birth are typically accepted today. However, understand that AMAB and AFAB may designate a gender history that your client may not wish to focus on, or it may be activating for them. So use caution and mirror the language and wishes of your client. You will see the simple terms man and woman in this column too, as there are people who identify as men and women who don't or no longer identify as having a trans identity. Next slide, please. So just as there are many ways to refer to someone's gender identity, there are many ways to refer to the way that a body can be. Here, the use of gendered language can be particularly detrimental and activating for past experiences of trauma and discrimination. The terminology on the right offers a better way to describe parts of bodies that do not implicate embodied gender and is inclusive of different types of bodies. Specifically, in the context of health screenings, you would not want to use gendered language when referring to a body part or a person's body. For example, using the word genitals instead of being specific about external genitalia. Also, you would not want to reference a woman's body or a man's body when speaking about a general configuration of parts, but instead you'd want to use more inclusive language, such as people who have cervixes or people with penises. As you can see, this language is inclusive of many different types of bodies and genders and is less likely to be activating of any dysphoria for your client. It can also be helpful to refer to specific body parts using the instead of your, as that might help create some distance and help mitigate some experiences of dysphoria. Lastly, but importantly, communication about trans and non-binary clients' bodies should only occur in relevant discussions related to client concerns. For example, asking about specific body parts to satisfy your own curiosity is unethical and can be traumatizing. You would only want to have discussions like these if you have a legitimate reason to do so. For example, coordinating care with other medical care providers. Next slide, please. So here we have another content warning. We will be discussing suicide, substance use, and other health disparities for the next 5 slides, which should take approximately 13 to 14 minutes. Next slide, please. So when looking broadly at the health disparities of trans folks compared to the United States general population, a stark contrast emerges. For example, 39% of trans folks surveyed in the latest United States Transgender survey, which I'll refer to from now as the USTS, were experiencing serious psychological distress compared to 5% of the general population. We know that suicidality is heightened in trans populations. Here you can see that trans youth are almost twice as likely to report suicidal ideation when compared to cisgender peers. Also, transgender adults are more likely to report up to 3 times as much current substance use. We'll continue to look more at the numbers for suicide and substance use risk to convey the importance of a trans person being able to access affirmative care. Next slide, please. So the USTS discovered that more than 80% of respondents had suicidal ideation at some point during their lifetime, 80%. But when considering suicidality, ideation is not the only rate that is high for trans folks when compared to the general US population. 40% of respondents to the survey had attempted suicide. In many other studies, the rates of suicide attempts were also found to be extremely high for trans populations. These attempt rates were found to be ranging from 30 to 60% compared to approximately 4% of the United States general population. Roughly, that translates out to at least 9 to 10 times the risk for suicide attempts for transgender adults. Another study we found that focused on trans youth reported that nearly 50% of their respondents reported suicidal ideation, and a quarter of their sample had reported an attempt. The researchers found that some factors were significantly related to having made a suicide attempt, and these factors were past parental verbal and physical abuse, sexual minority status, and lower body esteem, especially weight satisfaction. We also know that suicide is the second leading cause of death for young people in America, up to age 35. So being aware of the specific factors relevant to trans youth is important when working with your trans and non-binary clients. So let's consider generally, why are trans folks at such an elevated risk for suicidal thoughts and attempts? We know from the USTS that trans and non-binary folks who experienced family rejection, discrimination, or were a victim of violence were more likely to report both suicide thoughts and attempts. For people experiencing at least 4 instances of discrimination and violence in a period of a year, 98% of those respondents had considered suicide that same year. However, there are ways to reduce these drastic disparities. For example, it is known that access to gender-affirming care is associated with a lower prevalence of both ideation and attempts. Being an affirming provider for your clients is so critical and may have impacts you might not realize. An affirming relationship can be life-saving. Research from the Family Acceptance Project shows that family rejection can negatively impact youth health and mental health by lowering self-esteem and reducing supportive systems and increasing feelings of isolation. The project also found that LGBT young people who were highly rejected by family members were more than 8 times more likely to have attempted suicide. So as a provider, some of your work with trans youth can focus on building support for your client within their own family systems, as this has been shown to be a protective factor against suicidality. Next slide, please. Considering these facts, then, it is not surprising that we see a similarly elevated rates of substance use for trans and non-binary folks. The USTS found that about 1/3 of their respondents reported some type of drug use in the past month, which is about 3 times the rate for the US population. This usage included illicit drugs, marijuana, and non-medical prescription drugs. They also discovered high rates of cigarette smoking and current use of marijuana. Another study which focused on non-medical use of prescription drugs, or NMUPD, by transgender adults found that participants reporting NMUPD were also more likely to report usage of illicit drugs, and that NMUPD was associated with lower self-esteem, more gender identity-based discrimination, and more self-reported symptoms of anxiety, depression, and somatic distress. For trans youth, multiple studies found prevalence rates for substance use to be anywhere from 2 to 4 times higher when compared to cisgender peers. One study found that for trans youth, gender and sexuality-based harassment had additive and synergistic associations with smoking and drinking based on grade and substance. Another study found that gender minority youth were more likely to experience bullying and harassment in the past 12 months, and that victimization was associated with increased substance use. Yet another study found psychosocial risk factors similar to those that we've already discussed for adults, victimization and depressive symptoms, as well as a perceived risk of substance use were found to mediate the relationship between gender identity and substance use for a sample of transgender youth. So when considering the high rates of discrimination we've already briefly mentioned, it follows that some trans folks would employ drug use as a coping mechanism. And there are some aspects that need to be considered when planning treatment or interventions, especially in a risk or harm reduction framework. Next slide, please. So for example, some clients may present when they are already using hormones. Thus, you need to be prepared to coordinate care with other medical professionals to determine best courses of action if substance use becomes an issue. This is particularly relevant because of the way that subcutaneous hormone injections could activate addiction behaviors. It should be noted, though, that method of hormone delivery is largely employed by transmasculine folks who make up only a small portion of the larger transgender community, and that method of hormone delivery is not exemplary of typical medical care for all trans persons. As a clinician, you need to be aware of and attentive to the risks for relapse that occur in the environment around your client. It is important to understand when and how they may be facing employment barriers, health issues, social rejection, or general discrimination, as all of these risks make relapse a more likely scenario. Next slide, please. So, we must consider all the ways in which these health disparities are interrelated and compounding. Due to various sociocultural factors, trans and non-binary folks are more likely to report poorer ratings of overall health. This may be related to a lack of access to care or also discrimination events that occur at the sites of care. 1/3 of the USTS respondents who had seen a healthcare provider in the past year reported at least one negative experience related to their gender identity. That included verbal harassment, outright refusal of treatment, or having to educate the provider about transgender people in order to receive appropriate care. We know that transgender and non-binary people face much higher risks of physical violence and psychological distress than most adults in the United States general population. Black folks, Indigenous folks, and people of color, particularly trans women, are highly susceptible to violence and overt discrimination. This reality has become more known due to recent focus in American media. However, the failure of media outlets to use trans people's accurate names and pronouns is indicative of the way that transness is subverted and illegitimized through power dynamics. This type of media cycle perpetuates a climate for high rates of violence to continue. Trans and non-binary people are more likely to face housing insecurity, especially if they face family rejection at the time that they come out. Without secure housing, a trans person may face other barriers to health and survival. These other realities may also compound and lead to more disparities. For example, a Canadian study found that a history of transphobic assault, homelessness, underhousing, and sex work were associated with greater substance use among transgender persons. There aren't any federal protections in place to ensure secure housing for trans folks or to ensure adequate access to health care. Especially during the present time, trans folks are losing access to care that was established by government entities not long ago, and Danny's going to cover that a bit more later. Trans and non-binary folks have higher HIV prevalence rates, and these rates are especially heightened for trans women of color who may engage in sex work for survival. Even in metropolitan areas, trans folks face barriers to care, but this disparity is much more visible in rural areas, where care is usually through a limited number of community providers who may not have had as much access to trans affirmative training. A recent study of mental health care providers in a southwestern state showed that a majority of providers did not think that there were differences when working with LGBT and non-LGBT clients. This idea of therapeutic neutrality may harm LGBT clients in a way that post-racial dialogues erase the lived experiences and realities for people of color. All of these health disparities exist because of systemic barriers that prioritize and center cisgender and heteronormative experiences. When considering how all of these risks inform overall health disparities, it is helpful to use a syndemic lens. When considering all risks and realities for your clients, it may not be discrimination or substance use or housing insecurity or risky sexual behavior that is informing their clinical presentation or suicidality. From a syndemic perspective, it is more likely to be discrimination and substance use and housing insecurity and risky sexual behavior, and these factors all influence each other. That being said, not every trans or non-binary client will have issues with the aforementioned factors, but these factors are known to disproportionately affect trans populations. In planning treatment, it is beneficial to understand your client's experiences and to help your client set realistic goals within a harm reduction framework. You must be able to employ dynamic strategies to help your client reach whatever treatment goals you set together. And now, Sana is going to discuss microaggressions and stigma.
Hi, everybody. Sana here. So now we have a content warning for the next 5 slides, which will last about 10 minutes, during which I'll be talking about non-affirmation of gender identity, transphobia, and victimization. Next slide, please. So I want to address the concept of microaggressions. Microaggressions are an indirect form of discrimination that can occur in the form of comments or questions that single someone out based on group membership. Microaggressions can be distressing and painful even when the person saying the microaggression doesn't have negative or hostile intentions. In this case, I want to go over some do's and don'ts when it comes to dealing with gender diverse people in a healthcare setting. So you should always ask for someone's preferred language around their gender identity. This should be an explicit conversation. It's important not to assume someone's gender identity based on appearance and to use the language that the client uses in their understanding of their gender identity. Do invite conversations around your own biases and especially corrections to your language. There can be a situation where a client discloses preferred language and it seems to go well with the clinician, but then when the clinician accidentally uses the wrong language or makes a gendered assumption that doesn't fit the client, that client might not feel empowered to have a discussion around what happened. And that lack of discussion can erode the relationship. Making it explicitly okay for a client to correct you is essential. Do allow people to use the restroom facilities that align with how they identify. This can be difficult if the public restroom nearest to your office isn't gender neutral or isn't really under your control, but it's important to do your best to ensure your client has the choice of an appropriate restroom. So here are a couple of don'ts. First of all, transgender and gender diverse people often get asked really inappropriate questions by cisgender people about their bodies, such as what genitalia they have and what surgeries they have or haven't done. It's different if a client is wanting to process a surgery experience with you or figure out what changes, if any, they would like to plan to make to their body in the future, or if they have a particular emotional response to particular body parts. That makes sense to discuss because the client is bringing it up as a topic they want to address. If you're just curious, it's probably not appropriate to ask questions about body parts. And lastly, do not assume, stereotype, or refuse to use preferred language. I'll go into stereotyping later on in more detail, but these can result in an unsafe environment for a gender diverse person. Next slide, please. When a client encounters microaggressions from the clinician, they're less likely to return to therapy. Trans and gender diverse clients will respond to the points I just went over and may not come back to access care that is necessary for them if they encounter the don'ts, whereas the do's can strengthen the therapeutic relationship and make care more effective. Gender diverse people report avoiding accessing healthcare and cite microaggressions as one reason why. Avoiding microaggressions is especially important for the therapeutic relationship. If an environment is not affirming of a transgender person's identity, it is an aversive situation, and despite needing care, they may avoid it. This contributes to the health disparities that Erica talked about earlier. Next slide, please. Microaggressions are one aspect of the environment that can create minority stress. In the history of LGBTQ research, Meyer's minority stress theory was intended to explain mental health disparities between heterosexual and sexual minority people from a public health perspective. The model has been expanded upon to make it applicable to gender diverse people, and I'll go over that model in a moment. The important point about minority stress theory is that mental health disparities are caused by a disaffirming social environment rather than something inherent to being a sexual minority person. Basically, it is an alternative explanation for mental health disparities that depathologizes sexual minority identity. This was an important shift in research on LGBT people. It's important to note that the lens of gender minority stress is shifting the focus of the problem away from the identity and towards the environment for research on trans and gender diverse people. Next slide, please. Testa and colleagues expanded on Meyer's version to create gender minority stress theory, also adding constructs that may contribute to resilience. So in the left-hand column and the middle column, we can see the factors that may contribute to minority stress and negatively impact mental health. Discrimination could mean, for example, being turned down after a job interview because the interview found out that the applicant was transgender. Many jobs require background checks, and these will reveal prior legal names. So even without disclosing trans status, even with all of their paperwork updated, people get found out. There are many other examples of discrimination as well. Anticipated rejection is another one. For this construct, I want to emphasize the difference between anticipated rejection and something like social anxiety, where the rejection is unlikely to actually occur, and for gender diverse people, where rejection is a regular feature of the social environment. Gender diverse people may anticipate rejection because they have experienced this repeatedly before in relationships, or can sense the social climate really is hostile. So, for example, encouraging a transgender person to put themselves out there socially and test the anticipated rejection could be very detrimental because they're likely to actually receive that response. So that's something to keep in mind. Internalized transphobia is an internalized self-belief that there's something wrong with having a transgender identity. When a person is constantly encountering negative stereotypes and hostility about their identity, internalizing the negativity is something that tends to happen. This may contribute to depression and self-worth issues for transgender and gender diverse people. Concealment seems like a natural response to a hostile environment, but it takes a lot of work, and that can really wear down a person. For someone who's post-transition, it can look like avoiding talking about childhood because mentioning those experiences might tip someone off to the fact that they were raised in a different gender assignment than they currently present. For example, a former Girl Scout who identifies and presents as a man. For a non-binary person, it might look like hiding gender diverse status by not disclosing how they actually feel inside and not speaking up about misperceptions and assumptions. It can also look like having different social groups such as family, friends, and coworkers with different levels of knowledge about your identity. That can result in having to manage interactions to make sure members of different social groups don't meet each other. Otherwise, you could be in an awkward space of people using different names and/or different pronouns to refer to you in the same room, which is potentially confusing for everyone. In the middle column, we have victimization. This can take the form of verbal harassment, physical assault, or sexual assault. There are incredibly high rates of victimization experiences in the transgender community, as we saw in the statistics that Erica presented earlier. And then we have non-affirmation of gender identity. This can apply to non-binary people because only male and female identities are acknowledged in the larger culture. So non-binary folks who come out often encounter skepticism about their identity actually existing and have to explain their identity to people because it isn't something everyone knows is possible. Or it can refer to intentional misuse of pronouns or name as a way to refuse acknowledgement of a transgender identity, for example, by parents or other relatives who don't want to adapt to a person's gender transition. So this model also includes a couple of resilience factors that may buffer against minority stress. And these are community connectedness and pride. Finding others with similar experiences can be incredibly validating and healing, which is why it can be very important for gender diverse people to meet others with similar experiences and identities. This also helps to counteract internalized transphobia by normalizing the experiences associated with being under the transgender umbrella and fostering identity pride. Next slide, please. So what contributes to the experience of minority stress on a day-to-day level? Existing as gender diverse in a society with strict gender rules is hard. Gender diverse people encounter social expectations from family and community that rest on assumptions based on sex assigned at birth, like assuming female assigned people want to be moms, or that male assigned people will have certain interests or want certain jobs. Not fitting into those schemas that other people have can be painful and alienating. Appearance-based assumptions from strangers can be a daily hassle, coming out in things like small talk. Encountering sexist comments as feminine presenting can have an added layer of distress and confusion if you don't identify as female, even though it's not a fun experience for anyone. Additionally, transgender people run into problems in sex-segregated spaces, such as restrooms or locker rooms. There can be a serious safety risk to using public restrooms because of how cisgender people might react if they realize you're gender diverse, due to stereotypes that trans people are sex offenders and enter restrooms to victimize others. This is especially ironic because generally, trans people are the ones who get assaulted by cisgender people in restrooms due to prejudice. Also, in some religions, men and women are segregated during certain aspects of worship or for certain events. Then transgender people have to wonder where they belong or if they belong at all within their faith traditions. On a day-to-day level, we're all faced with gendered marketing. And this might seem superficial compared to some of the other things that I'm mentioning, but it's still something that's constantly visible. And if you've ever tried to shop for clothing as a gender diverse person, you know this is an issue. There are assumptions about shape, size, and bodies when it comes to clothing. For example, trans men can struggle to find masculine clothes that fit a smaller frame, and trans women often struggle to find feminine shoes that fit. Non-binary folks struggle to figure out how to express non-binariness using clothing that comes in two differentiated departments that don't apply to them. For gender diverse kids, the sex-segregated nature of toy departments has also been a topic of debate and discussion. But in general, marketing such as TV commercials make use of specific assumptions about gender in an attempt to relate with the audience in ways that can be alienating for people who don't fit them. Everyday language contains use of gendered words such as pronouns and sir or ma'am. Strangers attempting to be polite can instead be failing to affirm a transgender person's identity. And along with gendered assumptions comes heteronormativity as well, the assumption that assigned male and assigned female people will form sexual pairs and that this is the only natural way for humans to be. When transgender people are in relationships, it can be difficult for others to understand how the relationship works emotionally or sexually because there just isn't a well-known framework that accounts for transgender bodies or attraction. Next slide, please. So in just a moment, we're going to take a 5-minute break. Beforehand, we had included an activity called the Invisible Knapsack in the form of a handout. If you haven't had a chance to take a look at this activity, try to fill it out during the break, and then choose the reaction that best fits your experience of the activity using the poll that will appear on your screen. So let's take 5 minutes and then we'll get back into it.
Thank you, Sana. So for this piece, our speakers are gonna be referring to the worksheet that we sent on the original email that was sent, I think it was yesterday. We're gonna present some, I think it's a poll coming up with some questions related to that. If you didn't see the worksheet, just please go back to the email that I sent yesterday and just go, it's one of the attachments. It's a PDF document. But this is also a space to go to the bathroom, take some water, stretch your legs. Just a 5-minute break before we continue. Yes, the one that's called Cisgender Privilege Worksheet, yes.
Sorry there. So far we have 135 responses. And so still have some responses pending.
We can wait another couple of minutes.
So I have a question about how do you get to the poll? It should be visible. What I'm seeing is that people who haven't updated the Zoom, if you haven't updated your Zoom, perhaps you're not able to see the poll. And so just, kind of a note that you might not be able to see it if you don't have a most updated version of Zoom on.
I was also going to add that if you don't see the poll and you would just like to comment on the activity in the chat box, then that's also fine. Or if you have questions about the activity, you can put it in there for us to kind of address later after the presentation.
Thank you. Okay, so are you ready to share the results?
Yeah, let's see. It looks like a lot of people, it's given them some things to think about, some sadness, mixed emotions expressed here. Seems like quite a few people felt like they've discovered something new about themselves by doing this activity. And it did seem to help people to see the world from a transgender perspective a little bit better too. It seems like it's a little bit unusual for most people to be thinking about their own gender who were taking this poll. So yeah, basically it looks like the activity has kind of been thought-provoking in the way that we would really wanted it to be. So yeah, thank you so much for doing that and for filling out this poll and participating in this. So like I said before, if you have further comments and stuff about the activity, feel free to put it into the chat box so that we can talk about it later on. So I'm just going to go ahead and continue on with the presentation. So if you could give me the next slide, please. So these aspects of daily life that we've been talking about basically all add up into the concept of gender noise. Transgender people are constantly encountering a non-affirming environment every single day. And this can be distracting and distressing, which I think is understandable. It can be distracting to the point where people may have ADHD-like symptoms, and it can create or exacerbate trauma, resulting in traumatic stress. And it can have different impacts on different trans people, be experienced differently by the same person at different life points and in different environments. Now, these are mostly things that someone who's cisgender might never notice or consider, but they can be quite damaging to gender diverse people over the long term. Imagine being constantly reminded that who you are isn't part of the accepted cultural narrative you've been hearing constantly for your entire life, that your very existence is veering away from expectations that have been in social interactions with other people for your entire life. And that's what minority stress is like. Can we go on to the next slide? So I want to go over what is known as the transgender narrative with you, because this is how transgender people are being portrayed as the concept becomes more mainstream. The transgender narrative is a stereotype that attempts to make transness understandable and acceptable to cisgender people. It goes like this. I knew when I was 3 years old that I was supposed to be male or female, but that I was born into the wrong body. In order to become my true self, I underwent hormone therapy and surgeries in order to make my body congruent with my male or female gender identity. Now the problem is fixed and I'm completely a man or a woman. So famous trans people often cite this narrative, and it's become like a trope, a way to allow for the existence of transgender people without forcing cisgender people to change or confront any assumptions about the nature of gender. This stereotype is important to avoid with clients. Don't assume that every trans person wants to have every available medical intervention, or that they consider themselves to be born into the wrong body, or that they've known their gender identity for their entire life. Instead, listen to the individual stories and wants for the future. See the client and not the narrative. Next slide, please. So one thing the transgender narrative fails to explain is the fact that there are more ways to transition than just medically, and that individuals will choose different aspects of transition that they feel like they need. There's no one way to transition gender. Psychological transition refers to the process it takes to fully identify and accept one's gender identity. This process can take years, and often others outside the person won't realize that it's happening. That's why sometimes it can be a surprise to a trans person's social network when they come out and seem like they're making a sudden decision, when maybe they've been coming to this realization for a long time. Social transition refers to the process of coming out to important people in a trans person's life about their identity, and can include a lot of affirming and/or rejecting experiences. Legal transition refers to changing legal documents that reflect a new name and sex on things like a driver's license, a birth certificate, a social security card. This can be a lengthy and frustrating process fraught with gatekeeping and discrimination. Medical transition refers to medical procedures, including hormone treatments, hair removal, and surgeries. Some people choose surgeries only, or hormones only, or choose not to alter their bodies at all. And it's important to note that this doesn't make them any less trans. Transition is a very individual process. Next slide, please. You may have noticed that the transgender narrative does not allow for non-binary gender identities. If you identify as non-binary or under the non-binary umbrella, there are additional challenges you may face because the mainstream conception of gender doesn't allow for your identity. You may be constantly facing binary reinforcing language in the form of pronouns and the polite sirs or ma'ams, exclusion from gendered spaces, for example, restrooms, especially if your gender expression is in the middle of the gender spectrum. You may also face exclusion from the transgender narrative that makes your identity much harder to explain and potentially less acceptable to cisgender people. And I want to mention that even in the transgender community, non-binary people are sometimes excluded from trans spaces for not fitting this accepted trans narrative. And so non-binary people can experience a feeling of not being trans enough to identify within the umbrella, even if their own experiences align with other transgender people. So there's often exclusion even within the community itself. Next slide, please. Now I'm going to talk about a couple of different frameworks for the concept of gender dysphoria. The first one I'll mention is a way that community members talk about it. So gender dysphoria is most often discussed in terms of incongruence with one's body. This graphic does a nice job of pointing out different aspects of gender dysphoria to expand the concept a little bit further. A lot of this will overlap with what I already mentioned about gender noise. For example, social dysphoria has a lot to do with the social expectations, like expected ways of interacting, moving, and dressing that come with certain gender presentations. For example, a trans woman might feel distressed if forced to present male at work due to not being able to express herself through clothing, makeup, etc., or because she's forced to hide emotions or reactions in the moment in order to avoid seeming feminine to coworkers. Body dysphoria is distress relating to specific body parts that are incongruent with one's gender identity. For example, a person who was assigned female at birth might have chest dysphoria and feel distress when seeing, feeling, or being reminded of having a large chest. Binding might help, but likely won't completely eliminate the sensations and can't be done all the time. Some people choose to use medical interventions to address body dysphoria, while others don't for a variety of reasons. Mind dysphoria is a little bit harder to explain, and it consists of reactions to your own internal processes that may not fit your gender identity. For example, a trans man might experience dysphoria when getting emotional due to expectations around men's emotionality. Part of the transgender narrative is about trans people having the mind of their gender identity, even though they feel incongruence with their bodies. In reality, internal experiences are more complicated and subjective, and don't necessarily follow societal gender stereotypes. They can also feel incongruent and distressing. Next slide, please.
Excuse me.
Mhm.
I have a Hilda. She was locked out because she Zoom froze, so she's trying to join back.
I'm having the same.
Yes. Yes, anybody that is getting kicked off by accident, they can email me directly, nadia.kalinchuk at austin.utexas.edu. And also I can, I'm going to unlock it for just a few minutes to let everybody back in. Sorry about that, Sana.
Okay. Yeah,
Do you want me to pause for a minute while that happens?
Okay. Yes. Thank you. Okay.
All right, we'll pause for just a minute. Nadia, let me know when you want me to start up again, okay?
Yeah,
Sure thing.
It will be really interesting. While we wait, there are some interesting comments on the chat box if you want to look at them from about the worksheet from Robin, Trey, DK, and Edwin. Their own view being, part is like, I thought it was really interesting. I don't know if you want to talk about that while we wait.
I haven't been watching the chat box since I've been talking.
There's quite a few comments about the activity, and I can paste them in here as well, or we can save it to the end. I think that we've got a few people that are coming in,
Yeah, I'm watching the numbers go back up again.
okay, so it looks like everybody was let back in. I'm going to go ahead and unlock or lock back again.
All right, you ready for me to start up? We'll talk about those comments at the end since it seems like we're ready to get going again.
Sounds good.
All right, so as you can see, we have another content warning, this time for mistreatment by healthcare providers. And it's a topic that we'll cover for the next 4 slides. I don't remember exactly how many minutes. I think Danny knows that information.
It says 12 minutes.
Thank you. Oh yeah, I see it now. Okay, 5 slides, 12 minutes. Next slide, please. So this is the medical framework for gender dysphoria. And what you see here is the DSM-5 criteria for the diagnosis that gender diverse people receive in order to be provided with gender affirmative care. In other words, these criteria are used to gatekeep access to care. These criteria are incongruence between one's experienced or expressed gender and assigned gender for at least 6 months. And the options under that include incongruence in primary or secondary sex characteristics, strong desire to rid oneself of incongruence in sex characteristics, desire for sex characteristics of the other gender, strong desire to be the other gender, strong desire to be treated as the other gender, and strong conviction that one has typical feelings and reactions of the other gender. And then it's also requiring significant distress and or impairment in functioning. So knowing everything I just went over about gender diverse people's experiences, you can see, looking at these, there's a binary and absolute conception of gender implicit in these criteria. You can also see that it follows the transgender narrative, and by doing so, can be non-inclusive. Basically, it's attempting to give guidelines on who is trans enough to receive interventions. It also pathologizes the experience of being transgender. So I'm going to hand this over to Danny, who will continue on with the presentation.
All right, next slide, please. So hi, this is Danny. just want to say thank you for joining us all this far along in the process. You're on the third leg of the journey, so we're getting there. And thanks so much for your interest in trans people's care. So for my section, we're gonna start out with some things that we have had a lot of content warnings up, and that's because there's just a lot of challenges that this community faces. So we're gonna ending with some pieces of people's experiences that are negative, and then we're gonna talk about how we can make things better. So this is data from a qualitative study where trans and non-binary people interacted with care professionals. And it's just exemplars of things that could go awry and really could push trans people away from receiving the care that they need. So the authors categorize this into 4 different types of events. So the first one is blaming the trans person for challenges in their life. So we've pulled out extracts from a qualitative study here. So one trans person overheard their care provider saying, "Oh, they're reading too much on the internet." Or another person, regardless of the intervention, it's just never going to be okay for them. They're never going to be satisfied, essentially. So that puts blame onto the person who needs care for for their experience. The second form of stigma that occurs is shaming. Imagine that this is a trans guy who, a young trans guy who's just first receiving care from a provider, and they ask, "Oh, so do you think you're a little boy?" That can be really painful for experience that, especially in a derisive tone. Another form of stigma is othering, where there's a higher incidence of personality disorders among trans women. Overhearing that could, again, turn a trans person off from receiving the care that they need. And lastly, overt discrimination. So this extract says, "I assume they have multiple sexual partners. Is it my prejudice that maybe I'm testing my trans patients more often than my patients?" In this case, for STIs. So yeah, this is overt discrimination and prejudicial thinking, and again, can really turn trans folks away from the care that they need. Next slide, please. So as you may have heard, we're living through a pandemic. So we wanted to do a little bit of thinking about how being trans and non-binary might be difficult during these times. We have a poll. If you want to go ahead and start the poll up now while I'm talking about this slide, that'd be great. So we don't have hard and fast data right now, but we do have our impressions and things that we already know. I'll let you answer the poll real fast. Take a second. So here are the things that we hypothesize might be challenges for trans and gender diverse folks during this time. So trans folks who may have already had a date set for having some sort of medical intervention, a lot of those non-essential medical services have halted in the wake of the pandemic. So they may be in this sort of limbo period where they've gotten prepared to make some serious medical transition, and now that's not happening. So that can be a really challenging time for some clients. Also, a lot of folks, currently I work in student, and a lot of students are returning home back to their hometown environments, and many of them might have just been starting their coming out or coming in process. Excuse me. And returning home can be really non-affirming or activating for them. A lot of folks are describing the experience of recloseting themselves as they're going back to their home environments. So that can put an extra strain on them, especially if they were just at the point of stepping into an authentic form of themselves or joining a community that's really validating for them. We anticipate that there's going to be increased risk for self-harm and suicide. Again, due to these non-affirming environments people are returning to, and they might be experiencing more intimate partner violence. We've seen that during the lockdown, and we hypothesize that will be relevant for trans folks as well. Other trans folks can really, as we mentioned in the gender minority stress model, some of the resilience factors are community connectedness. And so trans folks may be really connected from their community right now, or connecting in different ways. Okay, so we're getting some poll results up here. It says a lot of people have not had a chance to check in, but some of the highest ones, it looks like, are insecure housing, or like I just mentioned, home environments that can be pretty negative. Also loss of income, yes, we'll get to that in a second. And then, yeah, increased suicidal ideation as well. So the next thing we hypothesize, again, as pointed out in the poll, is so trans folks already face discrimination at work and may face difficulties in the process of finding jobs. So this crisis may be exacerbating experiences that they're already having. And the last part is getting access to clinicians. So a lot of health providers and mental health providers are transitioning to telehealth formats. That may not be a realistic option for trans and gender diverse folks who are at home with their families and might not be out to them. So they may be kind of cut off from their lifeblood in terms of processing what's going on. Next slide, please. These are some, so zooming in from like the affairs to or zooming out, I should say, to national policy. We just wanted to quickly speak about what's going on in terms of executive branch decisions and legislation that is impacting trans folks. And really, it does ripple down into, I've worked with trans folks and gender diverse folks in a group session, and they really, it can really resonate, the experiences at these national and state levels. At the executive side of things, you may be aware of the military service ban. So any out transgender or gender diverse folks are being removed from military service at this time. Also, during the current administration, there have been at least 9 executive department rule changes that are allowing for religious liberty exemptions and de facto discrimination against transgender and gender diverse people in those departments. You may have heard also that Health and Human Services is working to remove protections for trans affirmative care under the ACA, which is nightmarish. At the beginning of the administration, the Department of Education rescinded guidance from the previous administration on more supportive experiences and policy for transgender students. And then lastly, the Center for Disease Control are barred for using in their official documents, among other words, transgender. And then at the legislative level, there are currently 26 states where anti-transgender legislation is being debated, even during quarantine. And these include bans to providing the affirmative therapy that we're about to talk about and that we're focusing on today. There's also bans against student athletes trying to join teams that align with their gender identity. They are trying to ban changes to birth certificate names and gender markers, as well as classifying certain types of medical transitions as child abuse. Lastly, there are some states that are trying to allow teachers to not be required using the names that are of their students, essentially. Also, lastly, I just wanted to say that as I was prepping for today, I uncovered that some of you may be familiar with the Harris Funeral Home case, where a transgender woman was fired because she didn't adhere to the company's gender dress code policies, and that was being taken up by the Supreme Court. And unfortunately, she passed away this week. So keep her in our memory as we continue our discussion today. Next slide, please. All right, so let's talk about models of care. All the stuff we've been talking about up until this point in terms of care has been under the diagnostic or gatekeeping model. And that's essentially the kind of de facto mold that you might have been trained under. So the diagnostic and gatekeeping model really, here are our critiques below that we have for that. So it can be really pathologizing in the sense of requiring a diagnostic label. So, we at the point are assigning gender dysphoria diagnoses to clients to get them access to care, but they really might not be having many other symptoms other than they are just seeking to align themselves with their gender identity. And it really creates this narrative of distress that something has to be going wrong just by virtue of having a transgender or gender diverse identity. It also ends up reifying a binary. As we looked at in the DSM diagnoses criteria, it's really one gender or the other language, and ends up, keeping clinicians and providers in this binary mindset. It can be challenging when you encounter someone who's gender diverse, essentially a non-binary trans person. As we remember our ethics, this model is really a threat to autonomy. It centers the provider's understanding of a person's gender over their own understandings, and really requires them to make some sort of valuative judgment to seek the care that they need. And lastly, it creates these unnecessary barriers that really might serve as roadblocks for trans people to get the care they need. They may have a negative experience and just decline for their care so all those are working from a diagnostic model or a gatekeeping model of care. Next slide, please. So what we prefer instead is the informed consent model of care by Schultz and colleagues in the references. So what is an informed consent model and how does it differ from a diagnostic or gatekeeping model? So essentially, we're throwing out that whole gatekeeping, throwing out that whole piece where the clinician is the expert in the client's gender experience, and really trying to form this alliance where the client is sharing their gender experiences and the clinician is serving as a way to bridge the care that they need. So this, by its very nature, is minimizing this power differential. It's really rooting the client's experience above all else, and really laying out the trajectory and helping them uncover what they would like to receive in terms of care. In terms of this piece down here, temporality of comorbidities, there are part of the standards of care, not required, but provide the guideline that a client should be in reasonable control of their other mental health diagnoses, and that can really backfire. So, for example, a client may be experiencing signs of depression that may be really rooted in the way that their physical sex characteristics are not aligned with their gender identity, but the standards would have us wait until we got the depression under control when the causality is rooted in their gender experience. So this model really prioritizes the gender experience and looking at it in a more nuanced way. It's also, essentially, we're looking to get informed consent and really take the client along with us in the process. I'll talk about some strategies for this as we go along, but really making sure the client understands why we're doing what we're doing, helping them recognize how that might impact their trajectory. And lastly, of course, focus determination, really, privilege autonomy from this model to get them the best gender care that they can receive. Next slide, please. So what can your roles look like from this model? So really, you can kind of serve as care coordinator. So a client might be, only seeking therapy for gender-related care at medical transition, and they've been told by a health provider that they need a letter from a psychologist. When they arrive to you, you can really serve as a coordinator for interfacing with that healthcare provider and helping them get the gender care they need. Another example, and this can be really relevant for those who are trans or non-binary or otherwise gender diverse clinicians. You can serve as a mentor. There's no one-on-one direct relatable experience, but you can tell them how, provide that disclosure to just give clients an insight how you may have walked the path and how to be applicable to what they're going through. And then lastly, you can serve as an advocate. So, step into your activist shoes if you got them, going out and advocating against all the nasty legislation that we've talked about or the executive actions that we've talked about, but also as an advocate on a more interpersonal sense. So, advocating for them in the context perhaps of your work setting. So maybe they are being misgendered by another staff member, and you can really advocate that staff member used their correct pronouns and their correct name. Next slide, please. So we wanted to provide some concrete takeaway approaches that can really help to be affirming to your trans and gender diverse clients. So we got about 8 of them here, and I'll walk through them. So the first one is to culture of affirmative and inclusive practices. And that's starting right at the very beginning of relationships that you're having with your clients. What this can look like is, especially in these times where everything's being done by having markers like transgender flags in your office space or in your Zoom space, adding your pronouns to your email signature or other websites materials or other advertisements can be really welcoming and cue off to your gender diverse clients that you are someone who may be a little bit more aware of the specific care they need. Second, make sure that your initial response when they disclose their gender identity is confirmative. Be really excited that this person decided that you were trustworthy enough to disclose this to you. And I think about, one of the worst responses could be, "Oh, totally had me fooled. I thought you were a real woman." Don't do that sort of, gender boundaries, and making sure that your first response is just really positive. Third, remember that not all mental health concerns are related to identity. So a person might identify as trans or gender diverse, but they may be seeing you because they need some help with their OCD or other, concerns that are just not necessarily related to their gender identity. Fourth, it's important to keep building expertise. So don't let this be the only workshop that you attend or the only time you think about this topic. Really delve in there, look in the research, look at, go on YouTube and listen to client experiences with providers and just get a sense of what it's like to be someone who's gender variant when they're working with care providers. Next slide, please. Fifth, we talked about those resilience and coping factors, the community connectedness and pride, steering your clients toward communities that you know of, spaces that might be affirming, whether that's a digital community or an in-person community. Again, a lot of things are digital now, can be really helpful for them to process and to bounce back from the challenges that they may experience. Sixth, recognize that transphobic experiences are distinguishable from other mental health disorders. So this is, notice that the environmental, the systemic, the structural impact of being gender variant can overlap, but not necessarily be one-to-one with other mental health disorders. So for example, we talked about gender noise and how it can really kind of present itself as inattentiveness or hyperactivity, or even mimic some symptoms of PTSD or other trauma disorders. And just recognize that the cause of that can be really important in doing your treatment planning and therapeutic work. Seventh, really educate your clients on the minority stress models that we talked about before. It can be really powerful to have a name or a label to attach to, let's say, internalized transphobia. The clients may come in and they might talk about how they really they don't understand why they hate themselves so much for their gender identity. They are just really having a hard time. They have these internal messages, and giving them that label and, of internalized transphobia can really connect them to experiences that other trans and gender diverse folks are having. And it can, really connect them into a piece of the community where they can process and get validation for that. And last, for our psychotherapy approaches, seek out mentorship. So maybe you have a supervisor that has some focus on trans and gender diverse care. And if not, maybe look for a consultation team or other mentoring programs that can really help you dig in if you are seeing a decent number of trans and gender diverse clients. Next slide, please. So what can you focus on in your sessions that instead of this diagnostic label and medical transition, what are the other factors that you could look at? So you might want to focus on resiliency and empowerment. So maybe the activism is something that they're on the burgeoning, they're burgeoning as an activist and really highlighting to them where they could go to join other people who are trying to expand trans and gender diverse rights. Helping them connect with that, and the resiliency and bouncing back can be really powerful. Also, you might have a client who is questioning or just at the beginning of their gender journey. And so you can do some identity exploration and really lay out on the table what you understand as different identity, or encourage them to look and connect with different communities to see what their gender identity label might be, and if they even want one. Third, helping them manage some of the challenges that we talked about earlier, the dysphoria and the gender noise that are occurring. You can really help them tap into some mindfulness, for example, that might be able to ground them as they're hearing sirs and ma'ams all day, every day. And then lastly, coming out and having conversations with people in their lives or other forms of transition are focusing on getting their gender marker changed. That can be a really powerful thing. On a driver's license, for instance, that can be a really powerful thing for a clinician to help out with. Next slide, please. So we wanted to include working with some trans youth, which have unfortunately become a political football recently. So what can you do if your client is a young trans person? So I think it's really important that, again, if you're someone who's just coming into their gender identity, starting their gender journey, providing a creative space to explore what that might look like, and really, helping them try it on in the safety of the therapy room can be extremely powerful. And that can look like, you changing the names in your system, their name in the system, or their in the system, helping them try on different pronouns and seeing what feels right can be super powerful. Also, as the clinician, you can step into role play for difficult conversations with adults. So these coming out conversations, or they could be having challenging conversations with teachers or other important adults in their lives, authority figures, and really help them develop that, that aspect of self-advocacy for them. Next, helping them develop boundaries about discussing gender. So when they have conversations with their peers, what are they comfortable saying and sharing? How do they set that boundary? How do they, how do they enforce that boundary when that's happening? And not just peers, but other adults in their lives as well. And lastly, you can really help them unpack what medical transitions look like if that's where the path is leading them. One example of that could be puberty blockers. So these are medications that trans youth can take that will delay puberty, and it can be really helpful. For instance, if their parents are not comfortable with making medical transitions during their youth, but once they are of the 8%, then they can essentially avoid having to go through puberty twice. So unpacking some of those medical transitions can be really powerful. Next slide, please. So you may find yourself in a situation where you're interfacing with a health provider who is looking for a referral letter. These are, the current state of affairs is that these aren't required necessarily for hormone replacement therapy, which is sort of one level of medical transition, but they typically are required for any sort of surgeries. That does not always, how do I phrase this? There may be providers that have different expectations on referral letters. So we bring up, you've heard WPATH from us before. This is the World Professional Association for Transgender Health. And that's sort of the standards of care more broadly that help sort of mental health and other health providers interface with each other. So if you are in a situation where you feel like a referral letter can be necessary, or if you're put in that situation, here's some ways that it might be useful to write that up. So you want to work with provide the identifying characteristics of the client, and this can be a really good space where you can draft the letter and then check in with your client if this is how they would like to be identified. It can be really empowering to collaborate on what this letter looks like. That's checking in with them of how they like to be identified. Can also provide the diagnosis. For example, if you are hesitant to provide a gender dysphoria diagnosis, but this is the make or break moment where your client's going to receive further medical care or not. You can explain to them why you're providing this diagnosis and what it looks like. You can provide a psychosocial assessment. So like a lot of times health providers will want to know if there are supportive friends, supportive peers, a family system that can, when they finish a medical intervention, that their client can return to. So that can be really helpful in that space. And also providing the clinical rationale for treatment. Typically, if you set it up as gender dysphoria, this is going to reduce that, is what most people would say. You also want to describe your course of therapy. So what you've done so far and how long your therapeutic relationship has lasted. And lastly, really try to again, stepping into this care coordinator role by providing the availability for yourself to consult as needed. Next slide, please. So these are some of the more, let me say, some of our less preferred criteria for hormone replacement therapy that are in the WPATH standards. So they ask for persistent, well-documented gender dysphoria, for capacity to provide treatment, age of majority, and well-controlled physical or mental health conditions. So these are not, what we want to emphasize here is that the standards are guidelines, but sometimes they're taken as doctrine. And so part of that challenge is, at least in the US, I'm seeing some chat down at the bottom, is getting the care that your client needs and adjusting to their health providers' desires. Next slide, please. So we've gone through so much of the challenges that trans and gender diverse folks face. So I wanted to end here with some positive aspects of trans identity. So there's a great team, Riggle and Rostowski and others, who focus on positive aspects, and they do a lot of qualitative work. So this is from their positive aspects of trans and gender identity.
Danny, it looks like you're frozen. Anybody else seeing that? There we go. There we go. There we go. Thank you so much, Danny.
Don't worry, there's an active thunderstorm going on outside. So I was like, timing is terrible. Okay. So yes, positive aspects of trans identity, you can really facilitate this space where somebody is feeling more authentic and more congruent with what they understand themselves to be. They may be able to develop more connections to community and have these stronger interpersonal relationships that they didn't think they could have. And also just building, they have this sense of personal growth or empathy, insight into themselves that really can be powerful for their experience. Next slide, please. So last week we went in with this cartoon. So this person says, on bad days, I see a man playing dress up in the mirror, and on good days, I actually see myself, I recognize myself. And after so many years of hating my reflection, it's absolutely surreal. So you can be a facilitator for this kind of gender euphoria for your clients, hopefully employing the informed consent. Okay, next slide. Q&A? Okay, we have some resources. We actually have a resource handout and a reference handout that we can share with y'all. If I imagine you might like that. So we have different transgender organizations. Next slide. Again, the standards of care that we talked about, and those cover some different areas and professional organizations. Okay. So invite my colleagues back in. And now it's time for some question and answer.
So Danny, some questions came in on the chat, and I do definitely want to acknowledge those questions that came in pretty early on. There was a question from Robin around why are sub-Q injections of hormones in trans masc folks increasing addiction behavior? Is it something physiological, or is there a link between needle usage past and present?
Yeah, I probably both and. So what the research suggests is that there's acute cravings in the same way even empty alcohol bottles can start that physiological response, for desiring to use again. So that's kind of what the thinking is there, that the needles become representative of and cue addiction reactions.
I don't think that there's necessarily a relationship specifically increasing behaviors. It's more so that association that some folks may have. I know that there's been some work done on needle fixation in the past, as well as just kind of aspects with behavioral components and related to ritualization and whatnot.
And so our next question comes from comment on the activity. And I think, Sana, you addressed this somewhat. As a trans person, nothing on the worksheet was new to me, and it did give me anything other than neutral emotions. But filling in the poll made me think my results might look like a gender skeptical response.
Yeah, I saw that, and I typed in there that I actually have a very similar response to that worksheet where I was reading it and I was like, wait, people don't think about this every single day? So I realized probably in the poll I should have put validating or something similar like that as an answer choice.
Mm-hmm.
But I appreciate also hearing from transgender clinicians who are participating today and kind of like relating to this material and everything. I was happy to hear from them in the chat.
And so there was another question that came in regarding a slide. And what was the symbol on the far right inside the person's head? I'm not familiar with that one. It was inside the mind example on the body dysphoria slide.
Can we go there by any chance? It's the one with the 3 pictures. It was during my part. I think it's a non-binary symbol, but I wanted to make sure. Yes, that is a non-binary symbol. So it's kind of like a riff on the male and female symbols, but then it has that little asterisk there instead. So yeah, that represents non-binary.
Mm-hmm. And so then another comment about the invisible backpack. This had a lot of comments. The invisible backpack. In the invisible backpack activity reminded me of racism activities I've been involved in the past. It didn't occur to me until now that I may be wearing my own invisible backpack as a cisgendered individual. So, yeah. And so then we had other questions as well.
Can I comment on that one?
Sure, yes.
Yeah, a lot of that worksheet is designed around, in a very similar vein to Peggy McIntosh's, race and ethnicity, invisible knapsack, and yeah, that's where it's coming from. So that's why you're feeling those vibes.
Wonderful. And so DK made a note about the potential exclusionary language around derogatory implication of multiple sexual partners, plenty of polyam folk who also happen to be trans. And I think Erica also responded to this later, but I'll leave it out there.
Right. So trans and polyam communities are not necessarily mutually exclusive, and polyam folks should obviously be respected and treated without prejudice. I think it was more so the blanket statement that specific provider was kind of applying to one particular patient, instead of considering that person's individual experience and behavior when considering their treatment planning.
Mm-hmm.
And so then there was a comment from, and I don't know if anybody wants to add to that, but Edelyn said, although my pre-surgery appointment was canceled last month, my gender confirming surgery at Mount Sinai in New York City in July has not been canceled or date changed. So that was just some information for us to know, what's happening in the community.
So congratulations.
Yes.
I hope it goes well. That's awesome.
And then Robin, you said, yes, what DK said around Erica's comment. Sorry, these comments come in at different times. So yes, what DK said, the assumption that trans people automatically have multiple partners is prejudicial. Testing them more often than other patients because of that is discrimination. But having multiple partners and being polyamorous is not in itself problematic. More frequent testing may be appropriate depending on circumstances. There's potential underlying assumption that practicing polyamory or requiring more frequent testing, should that be the case, are problematic, and that assumption is discriminatory.
Mm-hmm.
And so then we also had a question around school. So what would you recommend to address a student who wants to use pronouns and a name that their parent demands that the school staff not use?
So I had a visceral reaction to this as belonging to the trans community myself, which it's obviously it's not a simple thing if you're trying to balance like parents and kids in a setting where this is part of your job, and my gut reaction is always like, well, the kid needs to be affirmed, but obviously that's not the necessarily possible always. It's not always, it's not as simple as I would like it to be. So that was kind of the response that I had to that. Also a concern for the kid because that's a potentially dangerous situation to be living in a very non-affirming environment. So I just kind of want to put my heart out to that kid because that sounds rough. And that's pretty much all I have to contribute around that.
Well, I think about that as like kind of a hierarchy of needs, right? Like thinking of safety being the bedrock, and it's in my mind atrocious that a student can't just live their authentic truth and have the people around them treat them that way. But I think with working with a student like that, like really saying like, what do you have capacity to handle? How much, let's just take stock of how emotionally draining this can be to be just to keep putting up a fight and keep getting rejected this way. And it's really balancing two awful situations of this like constant non-affirmation or a constant fight, and really just thinking about what leaves them in the most safe place.
I think that I would also maybe consider, depending on what your work is with the child and the family and what type of interaction you have with everyone, maybe connecting with the parents and letting them know some of these effects, the really detrimental effects that family rejection can have. Maybe them getting them connected with projects like the family acceptance projects and showing them how important and necessary that family acceptance and support can be. Maybe also connecting them with other parents of gender diverse kids and connecting them into that community to help them maybe build a better understanding of where their child may be at inside their own gender journey. And then lastly, just if you do have a therapeutic relationship with that child, having your office be a place where they can continue to explore their gender and where you can be affirming so that they're receiving affirmation from somewhere. And then possibly also role playing with them how maybe self-advocacy could look with their parents and with the school. And of course, that would be dependent on the age of the child as well.
Mm. Yes, and so really another question that was really necessary too, because I guess that resonated with someone else, and they talked about that. I do want to get to one more question, and because most of them are comments, but one from let's see, around licensing. What credentials, and this is from Annette, what credentials do you need to have to write a referral letter? And I think you might have somewhat addressed that, Danny.
Yeah, the WPATH standards, I'm not sure off the top of my head. I believe a let me just put it this way. So I've written letters as a student intern under the supervision of a licensed social worker. So off the top of my head, I believe licensed social workers, LPCs, psychologists, I think would all be fair game for that. I'm not sure if you all have other experiences or other thoughts on that.
Well, I know that we, in our conversation kind of leading up to this, we're reminded of how the WPATH criteria are more suggestions and guidelines than kind of mandates. And there are some providers who are no longer requiring letters or referrals for HRT. So I think it really depends on your care team, who you're connected with, and checking in with them and finding out what's necessary within your specific care area. But yes, it is a variable type of factor.
So we made it through all the questions, and I do want to say that people have had a very have had responses to this in which they feel they've felt it in their body, they've felt anger in covering some of the content, and I just want to remind you to get engaged in your self-care, whether it's community care virtually or self-care, taking a walk after this webinar. Whatever you have. I do want to pass it off to Audie because we do have information about our survey and let's see. And we will be giving out all the information from this webinar to anybody who registered and attended. So.
Yeah, hi again. I just wanted to let people know that, I think there's people asking about the references. We have them at the end of the presentation. We have them all here. Just in case you want to check those out, we're going to be sending the slides to you as well. So this is the evaluation part that it's really important. So because I'm seeing folks leaving early. So before we go, just remember to complete the post-event evaluation of today's webcast. If you have your mobile phone, you can use the phone's camera and point it to the screen to scan the QR code, or copy and paste the link on the slide. I think if you can actually click the link. I think we did it so people could click the link and go immediately to the survey. If you are not able to do any of those things, don't worry about it. You will receive a reminder email about the survey and with the instructions of how to request the CEUs as well. So if anybody would want their certificate of completion or the CEUs, just remember to email me. My email is ari.acosta@austin.utexas.edu, or you can just reply to the email that I sent to y'all yesterday. Just keep in mind to put on the subject CEU so I know what it's referring to, because I'm going to have 200 people emailing me. So I really appreciate it if you could just put that on the subject. Well, and then just to make sure that everybody has the contact information, thank you so much for being here today. If you want to reach out to the speakers, here are their email addresses, and this is our information. We have a new website launch if you want to keep in touch with any new webinars that we're releasing or like coming up in the future. Just make sure to sign up to our newsletter, and any question that you have, just email me or Nadia, and we're more than happy to respond to all of your questions. So thank you so much for being here today. Have a happy Friday and happy, relaxed weekend.